All right, Dr. McMahon, you're all set to go.
Okay, great. Hi, everybody. My name is Maureen McMahon. I'm a professor of rheumatology at UCLA. I, really have a passion for treating lupus patients and for doing lupus research. I do both clinical trial research on lupus medications, and I also have done some what we call translational research, trying to investigate causes of cardiovascular disease in lupus and other things that can cause damage in lupus. So I'm excited to talk today about nonsteroidal anti-inflammatories and blood thinners. Some of that will have a little bit of overlap with some of the things I do looking at cardiovascular disease in lupus, as we'll talk about. Oops, so let me see how I can advance the slides here. Here we go. Okay, so first we'll talk a little bit about nonsteroidal anti-inflammatories. You may have had your doctor, say that you should take some nonsteroidal anti-inflammatories or NSAIDs. And here there are so many, I didn't list every single NSAID that's available, but I listed here the ones that we use most commonly. So, particularly things like ibuprofen or naproxen, naproxen. Aspirin itself is a nonsteroidal anti-inflammatory, and we also have some more specific nonsteroidal anti-inflammatories, which we call COX-2 inhibitors, which would include Celebrex in the United States. So how do nonsteroidal anti-inflammatories work? Well, we don't need to get too much in the weeds, but basically there's, normally in our body, there's an inflammatory pathway called the arachidonic acid pathway. And there are enzymes, COX-1 and COX-2, which will turn arachidonic acid into different types of prostaglandins. And these prostaglandins can have multiple different effects, some of which are inflammatory, including multiple ways they can increase inflammation, increase pain responses. But they can also have some protective effects as well. So they can protect the gastric mucosa. So that can lead to some of the side effects that we'll talk about. In addition, there can be some effects on blood clotting. So prostaglandins can interact with platelets and cause increased platelet stickiness and increased platelet clotting. And then there are some effects on the heart as well, including, making of new blood vessels and increasing cell proliferation. So when we have, your general nonsteroidal anti-inflammatory drugs like ibuprofen, naproxen, diclofenac, they can block both COX-1 and COX-2, which are the two different kinds of enzymes. Whereas there are more selective nonsteroidal anti-inflammatory drugs like celecoxib, which is the one that's available in the US, block just COX-2. So when you block just COX-2, you do get some of those anti-inflammatory effects without some of the effects that you would normally get, losing the protection of the gastric lining. So again, any medicine we use, we're always balancing risks and benefits. So talking about some of the risks of nonsteroidal anti-inflammatories, they're great medicines for relieving pain, relieving inflammation. And particularly when we're thinking about lupus, we know that a lot of the joint pain and a lot of the symptoms are caused by increased inflammation. So of course there are, great benefits to using NSAIDs, particularly in lupus patients. But again, there's downsides as well. So I mentioned that normally some of the effects of prostaglandins can be to protect the stomach lining. And so when you block that effect, you can have increased in stomach acid and dyspepsia and heartburn, but it can even lead to stomach ulcers. And so we really want to avoid that in patients who have a history of stomach ulcers, who have had a history of GI bleeding, or in patients who have things like Crohn's or ulcerative colitis in addition to their lupus, because those nonsteroidal anti-inflammatories can really increase the risk of problems. In addition, we know that nonsteroidal anti-inflammatories can affect the liver. So that's one of the things, if I have a patient who's taking these medications regularly, I always monitor for liver toxicity. Now, similarly, we know that prostaglandins can normally have several effects related to the kidneys. So they can cause normally dilation of blood vessels. So when you block that effect, you can cause constriction of blood vessels. So that can constrict blood vessels going to the kidneys. So that can increase or decrease your kidney function. It can also increase the kidneys' ability to retain sodium. So it can increase sodium retention, which can ultimately cause increases in blood pressure. There are some suggestions that there could be some interactions with reproductive health. So there have been a couple studies that have reported that it will decrease the ability of the ovary to release eggs, which of course can affect fertility. So if you're a patient who's trying to get pregnant and having a hard time, and you're taking a non-steroidal anti-inflammatory medication, I would recommend holding it in that circumstance and or talking with your OB and your rheumatologist. Now we know that these medications can sometimes have some toxic effects on the brain. So sometimes patients will have headaches when they start taking the medicine. You can even have really severe CNS or brain involvement, including things like aseptic meningitis or even more inflammatory type effects. Another big thing that we talk about when we talk about non-steroidal anti-inflammatories is heart toxicity. So I already mentioned that it can increase blood pressure. In patients with heart failure, we usually avoid using non-steroidal anti-inflammatories because of those effects. And in addition, we'll talk a little bit more, but there's been some suggestion that it can actually increase risk of myocardial infarctions in some instances. And then finally, there are some patients who have allergies to non-steroidal anti-inflammatories that can cause some problems with breathing or worsening of asthma type symptoms. So I mentioned, this is a very complicated slide, so don't get too concerned by it, but I really just showed it here because I wanted to just, kind of give you an idea of all the different ways, good and bad, that non-steroidal anti-inflammatories have been thought to have effects on the heart and risks for cardiac infarctions or heart attacks and strokes. And so you can kind of see here that again, there are good and bad sides to using these medications. Now, in particular, when we think about aspirin, you may have been told by your doctor to take an aspirin or a baby aspirin to prevent blood clots or to prevent heart attacks. And that's because normally COX-1, which is the enzyme that's targeted by non-steroidal anti-inflammatories, will cause increased platelet activation and increased vasoconstriction. And so by blocking that with an aspirin, you can decrease the stickiness of platelets and decrease the likelihood that platelets will accumulate in a blood clot. And that's why we use it to protect against heart attacks, strokes, and blood clots. But other non-steroidal anti-inflammatories or the COX-1 and COX-2 enzymes can have some negative effects on heart health as well. And so they can actually result in problems with smooth muscle cells and an increase and a decrease in some of the protective effects on blood vessels that you might see. So again, when we're thinking about using things like ibuprofen or naproxen or other of the non-steroidal anti-inflammatories, we really want to weigh the risks and benefits of using these medications. Again, I mentioned that these medications can have effects on the kidneys as well. So again, they can cause constriction in some of the blood vessels, increases in retention in sodium, et cetera. And these medications can also have some direct toxic effects on the kidneys. So again, if you have a history of kidney problems, we usually try to avoid using these medications and or really weigh the risks and benefits with your doctor. So I also mentioned the effects on the risk of bleeding, and particularly GI bleeding or stomach and GI tract bleeding when we use these non-steroidal anti-inflammatories. Is there a way to figure out how much of a risk that is for you? Looking at different risk factors that have been associated with a very high risk of GI bleeding. If you're over the age of 75, that's associated with a much greater risk. If you have a history of a previous peptic ulcer disease or bleeding ulcer, that's certainly a very high risk. Also, if you're on warfarin or Coumadin, it's also very high risk to also use non-steroidal anti-inflammatories. And so, generally I try to avoid doing that in patients who are on Coumadin. But again, talk about those risks with your doctors. Some of the other kind of medium risks, if you're kind of between the age of 65 and 75, again, if you have a history of ulcers, but never a history of bleeding or no complications, you want to use caution, but there would be a medium risk there. Using steroids with non-steroidal anti-inflammatories can increase your risk of GI bleeding, so you want to be careful there. And there can also be interactions with other medications. So if you're on SSRI medications, antidepressants, that can increase the risk of GI bleeding with NSAIDs. If you're using multiple different NSAIDs or high dose of NSAIDs, that can also increase the risk. And then finally, if you have no risk factors and you're not also using aspirin, then that would be considered a fairly low risk for bleeding. So again, you don't have to memorize this table or anything like that, but I put it in here to also mention that there are also some different risks associated with different medications. So this is something that you can use to figure out with your doctor if you are going to use a non-steroidal anti-inflammatory, which medication might be best for you. A medication that's really very selective for COX-2, which I mentioned at the start, like Celebrex, may be safer in terms of risk of GI bleeding. And when you look at some of the medications, they are associated with a higher risk for heart disease than others. So diclofenac has been associated with a higher risk of heart disease. There's other medications that are associated with higher risk of GI bleeding. So again, just to know that your doctor may choose or may recommend a different non-steroidal anti-inflammatory based on some of your risk factors. And one other thing I wanted to mention about using aspirin. So as I mentioned, aspirin is thought to be very protective because it binds to platelets and causes them to not be as sticky and not be as prone to causing blood clots. One thing to understand, though, is that other anti-inflammatory medications, non-steroidal anti-inflammatories, say, for instance, ibuprofen, also can bind to platelets. But unlike aspirin, which binds permanently to the platelets and has a permanent protective effect, the aspirin falls off after 2 hours. And so if you were to take ibuprofen and aspirin at the same time, the ibuprofen might bind to the platelets and then fall off, and you'd lose that protective effect if the aspirin wasn't able to bind. So the recommendation, if you are taking both medications, is that you should take your aspirin 2 hours before taking the other non-steroidal anti-inflammatory to try to reduce that competition between the two medications. So I mentioned a lot of these medications. Again, you always want to check with your doctor with any medications just to see if there's any risk of interactions between them. These are some of the most common interactions. I've mentioned a lot of these already. If you're taking any seizure medications, there could be interaction. Now, of course, many of our patients are taking both methotrexate and non-steroidal anti-inflammatories, and that comes up. I get calls from pharmacies all the time because there definitely is a risk of interaction if you're on methotrexate for high-dose chemotherapy purposes. For the most part, it doesn't cause too many problems in patients taking them for, for the reasons we use them in rheumatology, but just to be aware that that exists. And one other thing that I'll mention, that when you're taking an ACE inhibitor for blood pressure control or an angiotensin receptor blocker, those medications can be associated with an increased risk of having a high potassium. And when you take a non-steroidal anti-inflammatory with them, that can even increase that risk further. So you want to use a lot of caution. And again, this is just kind of to illustrate that, when you're kind of figuring out if you want to use these medications, you want to think about whether you're at high heart disease risk, high GI disease risk, and come up with the safest plan for you based on those risks. And again, I encourage you to talk to your doctor before taking any of the medications. And so just to kind of finish up, we'll also talk about some blood thinners. So the most common reason why lupus patients take blood thinners is if they also have antiphospholipid syndrome, also known as the lupus anticoagulant syndrome. And again, this is when you have the blood clotting antibodies that can cause blood clots, most commonly in the brain, or patients can have strokes. You can also have blood clots in the lungs, blood clots in the heart, or what we call DVT, or blood clots in the legs or even arms. And so, some of the ways that we diagnose antiphospholipid antibody syndrome is if you have a history of a blood clot, or these blood clotting antibodies can also cause pregnancy loss. So if you have one or more pregnancy losses less than 34 weeks due to preeclampsia or eclampsia, we may consider antiphospholipid syndrome. One or more pregnancy losses in an otherwise normal fetus after 10 weeks, or 3 consecutive fetal losses in pregnancies less than 10 weeks without any other cause. And so when we see those antibodies associated with these events or pregnancy losses, then oftentimes that will require lifelong anticoagulation in many cases. The most common used medications to treat when you have antiphospholipid syndrome, most commonly, ultimately, we'll use warfarin or Coumadin as a medication. That's an oral medication, usually the one you use long term. You can also use low molecular weight heparin, which is an injection. Usually we'll use that when we're trying to get the warfarin levels up to where we want them to be, or in situations where you're about to undergo a surgery or a procedure and we want to be able to stop the anticoagulation quickly. Or also use, because you can't use warfarin when you're pregnant, we'll have pregnant patients on low molecular weight heparin to avoid pregnancy loss. So just some other things to mention here. Warfarin is kind of a pain for any of you who have had to be taking it, because you have to monitor your levels, and that involves often checking your levels, and sometimes even a couple times a week. And it's not that convenient, of course. There are some newer medications that you may have heard of. They're called DOACs, or some of the trade names would be things like apixaban or rivaroxaban. They're oral medications that don't require the same kind of monitoring, so they're much more convenient for patients. But unfortunately, all of the studies that we have currently suggest that they are not as effective in patients who have antiphospholipid syndrome. So right now, unfortunately, we recommend against using those medications in patients who have antiphospholipid syndrome. And we're continuing to do studies and try to figure out if we can find ones that might be more convenient. But for now, again, we're stuck with Coumadin. Just to mention, I don't want to go too much detail here, but in certain circumstances, you may be on other kind of medications, such as antiplatelet medications. A lot of times, if you've had a heart procedure, these are the kind of medications that you would go on. But we don't generally use these medications that they wouldn't necessarily be considered effective for antiphospholipid syndrome. So thought I had one more slide there, but I guess I don't. But you know, some of the things I wanted to mention were some of the things that you have to watch out for when you're taking Coumadin, because Coumadin can interact with a lot of medications and supplements. So again, if you know, when you're on Coumadin, Coumadin works by blocking vitamin K, which can decrease blood clots. And so vitamin K is in a lot of things that we think are very healthy, leafy green vegetables, kale, spinach, etc. So you have to kind of keep your diet constant in those things, because if you have a week where you eat a lot of salads and then the next week you don't have any, your Coumadin levels are going to be going all over the place, or your INR is going to be all over the place. So, you know, again, you want to kind of be consistent, and that will help you and your doctor get your doses adjusted to the right levels. Some other things that can interact, many antibiotics can interact with Coumadin, and you might have to monitor your levels a little more closely if you have to go on an antibiotic. Even things like Tylenol or cold medications or antacids can affect your levels. So again, if you're taking those for a period of time, let your doctor know, and you may need to look at your levels a little more closely. There's some supplements that can interact as well. Vitamin E can sometimes have effects on levels. Also garlic, ginkgo biloba, green tea, St. John's wort, black licorice, and also things like grapefruit juice, cranberry juice, and alcohol can all affect levels. So again, I think keep things consistent. If you can avoid those things, then I think that may be helpful in the long run. So let's see, let me pull up. I know that there were some questions ahead of time. And let me see if we've addressed some of those answers already. So why do NSAIDs increase blood pressure? Again, lots of different ways it does it, but both by increasing sodium retention. So again, you should, if you're on a non-steroidal anti-inflammatory, you want to try to avoid sodium intake, but also through vasoconstriction effects. And can you take NSAIDs if you have kidney problems? So in general, my rule of thumb is that we really try to avoid them if you have any kidney problems. Especially, we try to avoid chronic use of NSAIDs. You know, if you need them for a very short period of time for, you know, an injury or some specific reason, then I would encourage you to talk to your doctor. There may be circumstances where you can just monitor things closely. But in general, my rule of thumb is to avoid. Do you have to have a vascular event or problem before you're put on a blood thinner, or can a rheumatologist put you on one for prevention? So things like aspirin we will use as prevention for blood clots. And sometimes the patients have a risk antiphospholipid antibodies. In those circumstances, sometimes we'll use an aspirin as well. In general, if we're talking antiphospholipid syndrome, generally speaking, we don't put patients on any blood thinners like warfarin unless they've had a blood clot or an event. You know, there are certain high-risk pregnancies. You know, if you're an older patient and you have multiple antiphospholipid antibodies, sometimes we'll think about using low molecular weight heparin in pregnancy. But again, that's kind of a case-by-case basis, and we'd make that decision with the OB doctors and patients and rheumatologists all together. NSAID's bad for your stomach. I think that we kind of talked about that. Can you avoid getting ulcers while taking non-steroidal anti-inflammatories? So I generally tell my patients to take some kind of stomach protection if they're taking chronic non-steroidal anti-inflammatory. So that can be either something like Pepcid or something like a PPI, which would be things like Prilosec, or other medications. So again, ask your doctor about that if you are taking them chronically. Are there other over-the-counter anti-inflammatory medications besides NSAIDs? So Tylenol is not an NSAID, but we can use that for pain, and it does have some anti-inflammatory properties as well. Otherwise, there's not necessarily a lot over the counter, but other things you can consider is that there are formulations of nonsteroidal anti-inflammatories in topical preparations. So if you use topical preparations like Voltaren gel or diclofenac gel, which you can get even over the counter, or stronger strengths with a prescription, that can sometimes have those anti-inflammatory effects without having a lot of the side effects. Can penicillin cause a lupus flare-up? Not that I'm aware of, but many times if you have an underlying infection, that can cause a flare-up of lupus symptoms. Do all NSAIDs cause GI symptoms? So all NSAIDs have the potential to cause GI symptoms, but if you have the more COX-2 selective NSAIDs, like a Celebrex, or even some of the general NSAIDs that have more of a COX-2 blocking properties, those can have a little bit less of a risk. So again, you should talk about that with your doctor if you are at high risk for GI complications. Can I take NSAIDs if I'm pregnant or thinking of having a baby? So this is kind of a topic all in of itself, and I'd encourage you to talk with your OB doctor. But in general, it's thought that up to week 20, it should be pretty safe to take a nonsteroidal anti-inflammatory. There have been some small studies that have shown some potential risk between weeks 20 and 30. But most OBs, if you talk with them, they'll, kind of weigh your risks and benefits and tell you if they think it's okay, or perhaps monitor you a little bit more closely. The general thinking is, in the last trimester of pregnancy or after week 34, you want to avoid taking nonsteroidal anti-inflammatories because they can prematurely close the baby's pathway, the blood pathway in the heart. It's called the ductus arteriosus. But again, I'd talk with your OB about that. Now, the caveat of that is that in patients who have antiphospholipid syndrome or antiphospholipid antibodies, oftentimes there is a recommendation to take aspirin and continue that throughout pregnancy. So again, I'd make these decisions all in conjunction with your OB doctor and your rheumatologist. And then what supplements do you have to avoid with blood thinners? Can you take magnesium or vitamin D? Those should be okay. Earlier, I listed some of the other supplements that you do want to try to avoid, including things like vitamin E, green tea, black licorice, St. John's wort. And finally, what is the best blood thinner medication for lupus? Again, every patient's going to be different and going to have different reasons why you're taking a blood thinner. So again, I'd talk to your doctor to help, make the best decisions for you individually. And I know we're kind of running a little short on time, but if you have any other questions, I answer them.
I think that you covered everything, Dr. McMahon. Thank you so much.
You're welcome. Yeah, hopefully we got it all in.